I will introduce Veloshnee Governder, and then towards the end of the session, Susan Cleary, who is on the call, will take over and will field any questions that anybody may have. So Dr. Veloshnee Governder is quite well known to some of us, as she used to work in the School of Public Health and Family Medicine in the Health Economics Unit, and she is still an honorary senior lecturer in the Health Economics division and in the unit. She now works in Geneva at the World Health Organization, and she is a scientist in the Department of Sexual and Reproductive Health research, and is included in a program of special research and development and research training in human reproduction. And she leads a team and a portfolio within that. Veloshnee did her PhD around TB and gender in Cape Town, and this is a passion of hers, considering inequality, as she is a health economist, and thinking a bit further around the lines of gender and I think reproductive health. So welcome, Veloshnee, and we really look forward to your talk. And if you'd like to share your screen, we can then hear about universal access to comprehensive sexual and reproductive health and the implications for guidelines and research.
Thanks, Lucy. Can you see it?
We can see it clearly.
Okay. Yeah, I never know what I'm seeing. Okay, I can see you. All right, let me do this. There we go. Oh, that's better. Okay, great. Lucy, thanks so much for that introduction. And always, it was really a pleasure to see all these familiar faces, Di included, Virginia, and I can see Maylene's also on the call. So lovely to see you all again. Adina asked me to do a session, a noon meeting session on some of the work we're doing in the Department of Sexual and Reproductive Health and Research and the special program, the Human Reproductive Program, on the work that I'm leading, and just to share some of that work with you. So I will provide an overview of our work, the department, and let's see, is it going down? Okay, hang on a second. This is where technology fails me.
There's sometimes just a slight lag. There you go, the outline's there.
Is it there? Good. Oh, great. Okay. So I'll provide an overview of the department and its work and our work within WHO, for those of you who may not be familiar with it, and then just speak to some of the work that I'm leading on advancing sexual and reproductive health and rights in the wider UHC agenda. So just to, okay. It's moved, Lucy? I think it has.
Yes,
okay, good. All right. If the slides don't change, just shout. Okay. So just to give you an overview of the department. So the department is the Department of Sexual and Reproductive Health and Research. So it's got a name change in the last year. Previously, it was Reproductive Health and Research. Now we're very glad to say that sexual has been included within that. And it also includes the special program of research, development and training in human reproduction, which is the interagency department, which is part of UNFPA, UNDP, UNAIDS, IPPF, and the World Bank. And we work in several technical areas. These include addressing needs of vulnerable populations, contraception and fertility care, maternal and perinatal health, prevention of unsafe abortion, and sexual and reproductive health integration in health systems. And this is the team that I'm located in. And finally, research, leadership, and capacity strengthening. I've included at the bottom of the slide, and I can share it again later, the links to our department, and you can learn more about our work. So just to give you some context of the work that we lead in the units that I'm located on, SHS integration, as we call it, in terms of the acronym. So our work is roughly guided or broadly guided by, firstly, the reproductive health strategy, which was adopted in 2004, which looked at how do you help strengthen the health system to better deliver sexual and reproductive health and rights, but also paying attention to gender equality, equity, and with a focus on a rights framework. And more closely to us right now, and what's central to our work is the SDG Agenda 2030. So WHO's work is mainly in one area is comprehensive access to universal health coverage, SDG 3.7. But for us in sexual and reproductive health, we're also guided by SDG 3.8, which is achieving UHC, but including financial risk protection, access to quality essential healthcare services, and access to safe, effective, and affordable medicines and care. But also more broadly in terms of 3.7 is universal access to sexual and reproductive health services, including family planning, information and education, and integration of reproductive health into national strategies and programs. So WHO's work is very much in terms of the SDG 3 on health and well-being, but also closely linked to that of relevance for sexual and reproductive health. We can't ignore is the SDG agenda on gender equality, and specifically universal access to sexual and reproductive health, paying special attention to the International Conference on Population and Development in 1994, and then 2004, as well as the Beijing Platform for Action and specific recommendations. So these are the guiding frameworks in terms of which we work. The work that I lead on, and that's located across the department. So our team is not a technical team that specifically works on a area of SRH like unsafe abortion or FGM or any of the others, but it tends to be much more cross-cutting. So we have work on health systems, humanitarian settings, and more recently on the importance of self-care. So I just want to be able to advance this broader agenda in collaboration with regional partners, other UN agencies like UNFPA, UN Development, UN Women, as well as civil society organizations, in collaboration with our regional offices across the 6 regions for WHO and the country offices. So there's 4 areas of work that we kind of focus on. One is the normative guidance, which you're probably more familiar with from WHO. Secondly is the research and evidence building. Clearly, there's been a lack of or insufficient evidence that looks at integration of sexual and reproductive health within wider UHC processes and plans, specifically at a country level. And that's one of the core areas of our work. Thirdly is around dialogue and advocacy. So it's global, regional, and country level dialogues. This is where we would engage with civil society as well as other partner agencies. So for instance, last week was the United Nations General Assembly with a special focus on universal health coverage. And we collaborated with civil society, specifically Women in Global Health, Women Deliver, and other civil society organizations to engage and speak to the role of civil society in advancing the agenda. And fourthly, we also work on providing technical support and capacity strengthening at a country and regional level. Last year, we worked with the International Planned Parenthood Federation. I think, sorry, it was not last year, it was in 2019 before we had lockdown. IPPF brought together all their member associations they work in probably 170 countries, and to strengthen capacity on UHC. And we provided guidance on how do we think about how do you integrate SRH within health benefit packages, and what would be the role of civil society. For today, I thought I would just speak to two areas of our normative work that we are currently engaged in, and we will probably be working on for the next couple of years. The first one is the section reproductive health interventions in the WHO UHC Compendium, and this work has been prioritized specifically because what we have found, and this has been over the past 10 years, is that sexual and reproductive health is not comprehensively covered within health benefit packages or essential health packages. You'll typically find maternal health will be well covered, but other areas that tend to be more sticky, sensitive, and contested, like, for instance, access to abortion services, access for services for LGBTQI populations, as well as gender-based violence, tend to be less covered. So this has been important for us to ensure that that SRH is comprehensively covered within the UHC Compendium. So we've been working over the past 2 years with the team in WHO that leads the work on the UHC Compendium. And the compendium essentially provides a one-stop shop of healthcare interventions to support priority setting processes at a country level. And interventions are included in the compendium if they have support and they're based on WHO recommendations. At the same time, we also recognize that there's areas where the guidance is not quite there yet. Infertility is one area. Sexual health is another. Access to services for LGBTQI populations is another area. So what we have in the compendium is placeholders that allows us to ensure that the services are there alongside while the guidance is being developed. And what our work right now on the compendium is to be able to map where the services will take place. So mapping what the service delivery platforms are for each of the services, what are the health worker needs, linking them to essential medicines and diagnostics, and to be able to identify and be able to eventually cost out what would be an essential package of services. And this has been one of the key areas of our work. Alongside this, and we have developed within this try to ensure that sexual and reproductive health is well placed within that, but also guidance on how to locate SRH services within the compendium. So I've just shared at the bottom of the screen, you'll see a link to our publication on SRH in UHC Compendium. And this is aligned with the if you're familiar with the Goodmarker Lancet Commission on SRH, which was published, I think, about 4 years ago, which made a strong argument for an integrated package of SRH services. So the package of services that are reflected in the compendium are aligned with what was recommended by the Goodmarker Commission. The one area which they included, which we have not, but will be included, is on comprehensive sexual education. Just because we haven't, it is part of SRH, but because it falls under education, we will have to include it as an area of cross intersectional work. The other important area that we've been working on, which has been guidance for achieving universal access to SRH in the context of universal health coverage, as well as primary healthcare. And in later last year, in 2020, in 2021 now, WHO published the operational framework on primary healthcare as a cornerstone for UHC. So the handbook that we've been working on for the past year and a half, almost 2 years. I don't see John on this call, but John was part of the advisory group. So This has been a long standing work of ours. It's gone through several iterations, but essentially the guidance is important for, it's targeted at a broad range of stakeholders beyond policymakers, decision makers, but including guidance for civil society organizations, as well as communities and international agencies like UNFPA, IPPF, etc. And common to both the guidance that we have in the handbook, which is forthcoming, is that there is a call for a step up of investments in resourcing and institutionalizing deliberative processes that actually enable the full participation of all stakeholders, and specifically civil society organizations. And these would include women's rights organizations, youth groups, marginalized and vulnerable groups across all stages of policy and programmatic processes. I mean, what we have found, and this is often the feedback that we get from civil society that work in the area of sexual and reproductive health, is that universal health coverage, priority setting processes are often highly technical and tend to be very much controlled by policymakers within the health policy, health financing. So the objective for us in developing this handbook is really to kind of demystify some of the processes, keep the language simple, and make it accessible to a much broader set of stakeholders. And in the guidance, we also include some of the areas that we are including, look at integration of SRH within health benefit packages, just because that's really the starting point for much of the discussion on universal health coverage. Also looking at if SRH services are not included within benefit packages, understanding what are the underlying reasons, and also advocating at a country level for criteria to be more inclusive beyond economic criteria and considerations, but to also include gender equality, human rights, and equity within that. We also have specific guidance on looking on service delivery integration, as well as accountability processes and measures for improving access to specifically quality comprehensive SRH services. So one of the challenges, when we look at UHC, there's a lot of focus and everyone gets hung up on the financial access to services and population coverage, but quality is often missed. And this is specifically important for, I guess, for all services, but for sexual and reproductive health, quality is important in that it also goes beyond what are some of the technical definitions of quality, but also how quality is understood and experienced by communities and those who are receiving services. This is just a slide that we've, this just includes some of the examples of some of the recommendations that we have for both government and civil society and communities in ensuring there's comprehensive access to SRH. So for instance, common to both, and this is one of the important advocacy messages that comes out of these processes, is creating and resourcing deliberative spaces that are safe. And this is something that we've been working together with our civil society partners. Secondly is also ensuring that when we're looking at priority setting processes, one is that they're also inclusive. Two, there needs to be transparency on what sexual and reproductive health services are included within benefit packages, and if they're excluded, what are the reasons? But also to be able to build capacity for civil society to be able to monitor the processes, but to also to actively engage and also to be able to give them the language of UHC to be able to engage and to be able to participate fully within these discussions. So that was just some of the work that we're doing in terms of the normative work and guidelines. But the other important area that feeds into our guideline work is strengthening the research and the evidence base. So we also know that we need to think beyond health benefit packages and setting processes, because we know that quite clearly that inclusion of services in a health benefit package doesn't always translate into service delivery and access to quality care. And quality care, as we know, is a complex concept, is understood and experienced differently depending on who the stakeholders are. And in thinking about this, we also have been guided by the fact that we increasingly know that we need to think beyond evidence that is research-based, more classical scientific evidence, but also what's experiential, that captures the experience of communities and those that are most vulnerable and marginalized and discriminated in society. And I think this has become also quite apparent during COVID, is access to services were always a challenge across low middle income countries, particularly where universal access is not quite there. For sexual and reproductive health, that's always been a problem, specifically in cases of access to abortion services, access to the youth, to family planning, for instance. But during COVID, this has become particularly pronounced. So one of the new initiatives that we've been working on, specifically in relation to building the evidence base, is a program of work on the what we're calling a sexual and reproductive health and UHC learning by sharing portal. We are working with this on this project, and we're hoping to launch this in early 2021 with UNFPA. And the objective of this portal is to create an accessible online resource of implementation stories that document countries' experiences in integrating SRH within the broader context of universal health coverage. And we're building content for this for the portal through two sources. One is through what's already been published in the peer-reviewed literature, and also through an open call for implementation stories. So earlier this year, we put out a call, it was in March this year, put out a call for implementation stories that was disseminated through our regional offices, country offices, and through our partner organizations like IPPF, UNFPA, UN Women, etc. What was quite interesting for us was the response that we got from civil society, less so from researchers and academics, even from decision makers or policymakers, but just a very, very strong response from broad civil society, and really stories that came from across all WHO regions, even some of the more difficult humanitarian settings as well, like Afghanistan, Somalia, South Sudan. And I mean, we can talk more about some of the stories that we've received in terms of thematic areas, but a lot of the focus has been on the role of civil society in moving the agenda forward, in engaging in either as service providers, where services are just not absent or not provided through the public health system, their role in engaging and in partnership with decision makers in building the evidence base, for instance, around abortion, being able to build the data on what is the extent of unsafe abortion and its impact on women and their families, and using the evidence to be able to advocate for inclusion of services within the essential health packages as well. And so, and that's been quite interesting, is being able to work quite closely with civil society in being able to sharpen the messages around the stories. And what we're aiming for with the stories are that they have to be reasonably short, not longer than 1,000 words, focus on what the sexual and reproductive health challenge is, what the intervention is, what the outcomes and the learnings. And we're really focusing on ensuring that the content is accessible, written in plain language, and that can be understood by all stakeholders, including the general public. So in terms of some of our future work, I think I'm just going to go back a slide. I realized I'd forgotten to mention some of our previous work. So some of the ongoing work we have, sorry, I'm just taking you back, is the evidence base, coming back to the question of how we are trying to strengthen evidence base. One is also through in-depth country case studies. So we've undertook 3 country case studies, again, looking at integration of SRH within UHC processes. One in terms of the broader, the law, and this is specifically important when we're looking at, for example, access to abortion services. If the law is restrictive, then the service cannot be provided. So we've looked at this for 3 tracer conditions: maternal health, abortion services, and gender-based violence. And we selected those conditions based on a couple of considerations. One is for maternal health, there's been long-standing commitments to maternal health, and that often is less controversial, but it's been sometimes been reflected within the MDGs and within the SDGs as with very clear targets. But there are always, challenges in terms of quality of care do persist even when there's coverage. We selected abortion services just because it's always, it's always highly contested across both high income and low income settings, particularly because it also relates to gender and equity. We selected gender-based violence because it requires working across different sectors, with justice, police, etc. But it's not just around service provision, but it also requires preventive services as well. These case studies have been complete, and I can even talk more about it in the discussion on some of our findings. But we're at the stage of where we've just finalized them, and just working with the ministries of health for them to review and approve the findings, just to make sure that they have no objections to any of the content in that. And finally, we also worked in 2020, last year, with the journal Sexual and Reproductive Health Matters on a special issue on UHC and sexual and reproductive health in focus. And that was quite a useful, interesting exercise, just because, one, there was a lot of papers that came forward that looked at coverage of sexual and reproductive health within essential health packages or health benefit packages. But one of the areas that tended to be a gap was around access for marginalized and vulnerable groups, and questions around how we can use gender and rights to improve access to care as well as quality. And I think this is, this is my last slide. In terms of future work, so our normative work is ongoing. In terms of some of the future work around strength and evidence base, there's 3 areas that we are working in, and we're kind of trying to build up a portfolio of work. One is around strategic purchasing for improving quality of sexual and reproductive health services. We have some specific work on access to family planning in that area. Secondly is interventions to improve the competencies of the health workforce to deliver high quality SRH services in primary care settings. Right now, we've just initiated a scoping review to see what might be interventions that have been shown to be effective. And the third area of work, which is still very, very, very new, but was kind of motivated by some work we did last year in terms of access to quality uterotronics, in terms of averting or addressing postpartum hemorrhage. And this kind of highlights the importance of quality SRH medicines and products. which is obviously critical in terms of, one is ensuring in terms of a health systems intervention, but clearly during COVID as well, we've seen disruptions in terms of both procurement and delivery of sexual reproductive commodities during this time. So it's another area that's become important for us in terms of priority. So I'll stop there, Lucy, and hand over back to you.
Hi,
it's Sue. Hi, Sue.
Lucy and I are sharing the chairing of this meeting this afternoon, and thank you so much, Velosh. That was really interesting, and of course wonderful to see your face after maybe 18 months since I last saw you. And thank you for sharing your fascinating work that you're doing in the WHO. So colleagues, now's your big moment to engage with Velosh and pose some questions. And what I suggest is that you can pop a question into the chat, you can raise your hand, you can turn on your video, which would be fantastic. And let's see if you have any questions. And while you're thinking about that, I've got a couple of thoughts to, I'm not seeing any hands at the moment. So while you're thinking about what you want to say, I have a couple of questions to engage Velosh with, if that's okay, Velosh. Are you okay, Velosh? Are you plugging in or something? Are you muted? Still muted.
No, there we go. No, I was shifting around because I'm playing hide and seek with the sun. So there we go.
Okay, so just unshare your screen.
There we go. Great.
Yes. That's it. That's it. Okay, great. So Velosh, I'm also really fascinated by this whole area of work to do with thinking through how to do priority setting for benefits packages for universal health coverage. And without a doubt, the space of sexual and reproductive health is essential to what we ought to be doing within healthcare provision and for UHC. But, you know, I'm interested in methods as well, and I teach economic evaluation and health technology assessment and so on and so forth. And one of the tricky things, I think there's two tricky areas in your space. And the one is, how is it that one approaches questions of equity and value for money when the gain from the intervention is not a health gain in the normal way that we would think of it? So with contraceptive services or with abortion services, it's not so much about the QALY or the DALY or even the health gain in natural units. So that's the one area. And then linked to that is the issue of the intersectoral delivery of the services. And so, you know, if we're dealing with something like HIV treatment, it's really very straightforward, because what we are seeking to do is to assess the cost effectiveness from the provider's perspective. One then puts the health gain as a QALY or a DALY or a natural unit, and one compares it to the marginal productivity of the health system as expressed in the cost effectiveness threshold. And it's straightforward. It's clearly cost effective, it's clearly value for money, and it clearly should be an investment, and also because it's largely a health sector investment. So it's a very straightforward argument to make within a priority setting space. But this is, there's a lot of different values that are gained through sexual and reproductive health services. And I was just wondering, is there debate about that? And if so, what is it? Is it that people are wondering about measuring gain as capabilities, or are they measuring gain as functionings? Is it about freedom? You know, what is the gain that one is seeking to measure, or is it just sort of that people say, oh, well, that's just nonsense and we should just not look at it in that way at all? So what are your thoughts on that very complicated question?
It's a very complicated question, Sue, but priority setting is complicated. I mean, yeah. I think, so some of the experiences that we've had, I mean, it's, you know, and this is again what we've been trying to do within the compendium as well, is that one is make quite clearly the links across the SDG platforms. So even for priority setting at a country level, it cannot just be around health, because for sexual and reproductive health, it cross-cuts with gender equality, and making that very, very, very clear. So if we're going to talk about access to services for groups that are vulnerable, marginalized, LGBTQI populations that are typically marginalized, and the service provision cannot just be made on terms of whether it's cost effective or not. So what we are arguing for is that the considerations have to move beyond that, to include rights, to include equity. So within WHO as well, there's a team that works on gender equality, equity, and rights. Within our department itself, we have a gender advisor and a human rights advisor. And I think part of it is this discussion around making it a highly complex technical discussion is we need to try to take a step back, because every discussion, what is prioritized cannot be based on economic criteria alone. So we've seen, like, for instance, in Malaysia, they moved, even though the country and many countries have signed on to the CEDAW. Do not ask me what CEDAW stands for right now, but it's around economic and women's rights and advancement. So many countries, and this was like a defining moment for the International Conference on Development on Population, is many countries have signed on in terms of gender equality, but they don't necessarily walk the talk. So the question then is, for civil society, is what they did in Malaysia was, again, do we advocate this? Do we support this? But this is what they did in Malaysia was they advocated for inclusion of services for the prevention and treatment of gender-based violence based on public health grounds. So they looked at the public health impact, the economic, the social consequences. And so civil society knew that they could not advance the argument in terms of rights within the social, the cultural context of Malaysia, but they could do that within looking at the public health impact. So much of it has to be, what we see has to be strategic in terms of how countries advance these arguments. And what we are arguing, and this is where we have a bit of a battle with our colleagues in some of the health financing and the economic evaluation groups, is they argue, well, if we are inclusive and if it's based on equity, of course, you'll have comprehensive access to comprehensive sexual and reproductive health. And we say, no, that doesn't automatically happen, because your inclusion criteria has to be wider. Two is often, it's the health financing people and HTA that's making these decisions. But the discussions are never inclusive of those groups that are affected or marginalized. So how do we, open up those spaces? I mean, of course, for WHO, we cannot push and say you have to open up those spaces, but we can encourage. Is where do you create some of those more open dialogues? So one of the other areas that they're working on is through the World Health Survey and looking at health technology assessment as a priority setting process at country level. And we've trying to use that as another opportunity to say, okay, is it inclusive of different stakeholders within those discussions, or is it just still a technocratic discussion? Because it cannot be based on qualities and dalis alone. And I think if you widen the discussion and you make it less technical, then the shifts do happen. I mean, Malaysia is one example, but there's many more. There's much more than that. It just comes to mind too.
Thank you very much. I'm very keen, just to follow up, and then I see John's hand is up. I'm very keen on the idea of procedural justice as being actually, because I mean, reasonable people will disagree about how we should set our priorities or what we should prioritize. And I think that we should accept that that is the case, that there is no right answer to these things. There is a certain amount of money, but there is no right answer, and there will never be a single answer about how we should spend our money. And so it has to be within a process of procedural justice. And that for me then encompasses what you're talking about with the deliberation and the inclusion, and that the discussion needs to be in a way such that it's accessible on all levels to the different stakeholders. And I think that, you know, if in my lifetime I see that happening more in South Africa, I will be a very happy person. And I think it would be a good investment. It would generate social capital, and it would not actually be that expensive, but it requires a lot of political will, because once you become very explicit about what decisions you're taking and how you're taking them, it becomes more, you have to put your money where your mouth is then. And so in my feeling, a lot of people like to keep things technical and implicit and complicated so that nobody really understands what's happened or how the decision has been made. But I could go on and on and on, and I'm going to rather say hi, John, and please turn your video on if you can and pose your question.
Hi, good afternoon, Lush. Nice seeing you again, and thanks, that's you. I think what I wanted to add to this is the issue of people. Having worked in the adolescent space, for example, I could tell that one of the biggest challenges we have has to do with our mores, our culture, and our norms. There are some, you clearly said, which I totally agree, that it's more comforting to hear about reproductive health, especially in many African contexts. But the moment you bring in sexual, it changes the whole dynamics. I've worked, for example, in Senegal, where we could not push the word sexual into our write-up. We had to remove it totally, especially dealing with adolescents. So then how, beyond just wording this into high-level documents and setting out how to achieve them in high-level documents, either at an international level or at the national level, even subnational levels, how do we kind of make it come alive so that the people we're really interested in would also make use of the services and buy into them? Because in the end, if if it's well written, but our cultures, our norms, our practices, our mores don't allow us in any way to use such services, especially I'm talking about the adolescents. How do we navigate that water, if you have any idea? Thanks.
John, that's another huge question. I mean, I think that, obviously that doesn't depend on global guidance, you know, that very much depends on what country level process, but also there's what I've learned. I mean, I was on this discussion last week. It was a side event for the UN General Assembly, on SRH and UHC. And we had on that panel, so, I mean, for us in WHO, it's really around the normative work and some of the evidence. But the panel was also, there was a speaker from Botswana. She represents the LGBTQI community in Botswana. There was a young woman from Kenya who spoke on access to adolescent services. And what you really see on the ground is how they are building partnerships amongst themselves. So partnership, and I think one of the challenges we've seen in recent years is funding cuts for civil society, or civil society is being muzzled. But civil society, and what was quite encouraging last week, and again, this was on that panel with two young Africans, and we know there's the level of conservative, or the what they see as potential, the challenge for family values and Western influence. But clearly there's a lot happening on the ground across many countries in terms of pushing against that. And I think what's quite affirming to see is that civil society organizations across the world, particularly being youth-led, I mean, the youth have the slogan, what is it, not about us without us, and that came from the disability group. But that's something that they've picked up in terms of leaving no one behind. and they've been quite vocal. So what we try and do within WHO, and again, it's not WHO, but it's there's a special program, the Human Reproductive Program, which operates on its alongside the department, but engages much more with, has a capacity to engage much more with civil society. And that's where we can try and encourage those spaces. So if you're looking at adolescent health, we have a team in our department that works on access. And again, as I was saying, you know, the stories that we received for the Learning by Sharing platform, probably the majority of them were coming from youth, civil society, and how they're pushing forward the agenda. So they're not waiting for us to give them solutions, actually, you know, they're not waiting for the normative guidance. So we can, I think what we are able to do is provide the evidence, you know, where we can, and good evidence that's reliable, but at the same time, work with them to also co-generate that evidence, because you can't make decisions without evidence. I mean, that's quite clear from, you know, priority setting. So Sue's question around, you know, what is beyond the economic criteria is what is the burden, and not just the disease burden, but what is the economic, the social impact of it. And I think that's where they've been able to kind of move that agenda forward. So we provide some of the normative guidance, they generate the evidence, we can support that, and that itself kind of reinforces some of the messages. And what we are able to do, I think, because WHO is a member state organization, is once we have a guideline that's up, is then the member states or civil society takes that and says, well, this is what's being advocated, and then they're able to push for that. So I think it's only through partnership that, you know, we can move the agenda forward. And again, around norms and sexuality, it takes time. You know, it's very small, it's extremely small steps around it. But it's something I can talk to length about, John, in terms of some of the work that's ongoing, around, specifically around sexuality.
Thanks, Velosh. John, I think you are happy. You don't have a follow-up question. A lovely discussion there. Marlene, I see your hand up. Please, the floor is yours.
Hi, hello everyone. I really just wanted to say hello to you, Velosh, in person. I haven't seen you for such a long time. So this is a wonderful opportunity. And of course, I absolutely enjoyed your talk and kind of wondered how on earth do you navigate that wide portfolio of work, which is, it's quite a wide portfolio of work. But what I wanted to ask, and it relates to Sue's initial question around priority setting. So we of course know at a country level, different programs would argue for their specific needs, and that each program or each area of work feel that their work has to take priority. And so from the child rights point of view, we would argue, and of course it's very, very intersected with sexual and reproductive health, but there's so many different components at WHO that would impact and allow or potentially conflict with or hamper the prioritization of sexual and reproductive health. So I just wondered, out of interest at the WHO level, how do you as different groups work together? Is it similarly the silo effect as we often find at a country level and grapple and struggle with? And how do you reconcile when there's slightly conflicting agendas that would be offered to member states that now have to make sense of these prescriptions? So it's that typical sort of, I think, higher level policy, I think, suggestions or prescripts, and then how, you know, if we do it in in unintegrated ways, then it's difficult for countries, especially where the capacity is not that great, to make sense of how to integrate all of these different agendas in a way that would make for a coherent country agenda. So never mind working across sectors, how do we actually work within the same sector? So I just would like to hear from that level how you experience those kind of dynamics.
Maybe I think that's an offline discussion. It's very much an offline discussion. No, I think for sure that tension absolutely exists. I mean, last 2 weeks ago, our colleagues in NCDs are developing guidance on prioritizing NCDs within benefit packages. And the team lead was saying, oh my God, we've come to this so late. Have we completely lost it and everybody else has advanced? And I knew what he's talking about. HIV clearly has made huge advances and everybody else lags behind. And so, I mean, that I would agree. There's always that tension of what is more important. And I think if you work in your area, then that just becomes, it's also personal. I mean, I think with sexual and reproductive health, it's highly personal. Even within our department, we have colleagues working on violence against women it's not versus, we be collaborative on prevention of unsafe abortion. I think it's not easy working across. That much is clear. But I think there's often opportunities where we have that ability to kind of work across. So we've been working, for instance, as an example, with our colleagues on NCDs, on supporting them on how they develop their guidance for costing NCD interventions within benefit packages. And we're sharing our guidance with them. Hopefully others will share their guidance with us, but we try and move the needle kind of slowly. What I think helps is the work we've had across WHO on the UHC Compendium, which is across all technical departments. And that, I think, helps in reducing some of the competition, if you like, or the rivalry, potentially, because it basically says we're putting together a compendium of, I don't like calling it best buys because it means like you're shopping through it. But what are recommended interventions? This is what the guidance is. And being able to provide the data, including where will it be delivered, across all, being able to provide it in a way that's less judgmental, but comprehensive. And I think that's potentially one way of moving forward. But I agree. I mean, I don't have an answer. I mean, to be honest, we have to work across 3 levels. So when we say 3 levels, it's the U2 BIDI. So working across the headquarters, our regional offices, and the country offices, we don't often have that alignment, even when we have to work with health systems. So if we do not have, what I think helps is just building relationships. So where we build strong relationships, we know that we can easily pick up the phone and say, okay, what's happening, with health financing? But I come from sexual and reproductive health, and we can have a discussion. Yeah. So I think it's collaborations and it's building relationships where it breaks some of those silos and the division, because we're all working with limited resources and the competition around it.
Yeah. No, thanks, Velosh. I think, of course, I mean, it will always be a slightly elusive, I think, goal to completely work in an intersecting and integrating way. But I really appreciate you mentioning the issues of relationships, because I think that's what we've experienced during the COVID pandemic response, that relationships and prior relationships really mattered in being able to put certain things in place. So yeah, absolutely critical, the software of the system. So thank you. Really great to see you.
You too, Megan.
Thank you, Maylene. That was another really great discussion and lovely to see your face. And interesting to hear the discussion about relationships, because I think in some ways at the stage of the COVID pandemic where we're at, we had relationships that existed prior to COVID, but after such a long time of not seeing people, I don't think that it's easy to keep those relationships in the same way. And I do think that one needs to actually share air with people in order to develop certain kinds of relationships. And perhaps there's been improvements in other kinds of relationships where that was never possible to share air, but now at least it's possible to share screen time and have video working and so on. But there's nevertheless this sort of deep need that I feel to have a noon meeting in person. And I don't know whether I'm alone in that regard.
Yeah. No, I think that's such an important point. Just completely on the side. Before this, I had another meeting, and I think the person didn't realize it was virtual, and she said to me, "In which office are you? I'm looking around for you in the School of Public Health building." And of course, so that was interesting.
I wish somebody would say that to me. In person. Colleagues, any other, we're sort of almost out of time, but any other last round of applause from John? Any other last comments? If not, Velosh, thanks so much for joining. Because I can't see you on a face-to-face basis, this actually was fantastic.
Same here, Sue. Same here.
And I think it was an interesting I think it was a very interesting presentation, and we'd love to have you back again. And it was certainly a very interesting discussion. So thanks to those who contributed to it, and thanks to everybody else for coming along. And Velosh, last word to you.
Last word, Sue. I mean, I think I covered a lot very superficially, but as Maylene said, it seems like a huge portfolio of work. I don't do it alone, Maylene. I have to say, an incredible team of young people. And I say they all are young and they're way smarter than I am. So the one thing I've learned is surround yourself by young, smart, technology savvy people and they move mountains. So yeah, I have a great team that I work with. Love them to bits. And and they move this work forward for us.
Beautifully said, Velosh. Okay,
so thanks everyone, and have a great afternoon, and keep in touch. Lovely seeing all of you again.
Yeah.
Thanks so much.
Bye-bye.
Bye, everyone.
Bye-bye. Cheers.
Bye-bye.